Ladies and gentlemen, good morning, good evening. It's not in the morning, it's the evening. I greet everybody who is here. Thank you for attending this meeting. The meeting for today is as entitled Fibroid Tumors of the Uterus. These fibroid tumors of the uterus are commonly called by scientific name called leiomyomata. If it's one, is called leiomyoma because they are from smooth muscles. My name is D.T. Mahapa. I'm a urogynecologist here in Polokwane, and I welcome you all to this webinar. We are going to talk about tumors that grow on the uterus. This is one of the common conditions of a female uterus, a female womb. Sometimes fibroid may have symptoms, sometimes they may not have symptoms. May be found incidentally in the surgery for other conditions. You find that you operate a patient for another condition, you find fibroids there because more often they've got no symptoms. Or sometimes you do hysterectomy for other reason, maybe precancerous condition, and find that it got small fibroids there. Usually, if they are small, they don't give pain. They are commonly called fibroids because they have in them a lot of fibrous tissues. Actually, they should accurately be called leiomyoma as they arise from the smooth muscle of the uterus. Sometimes people are lazy to speak. They just call them myomas. I heard a myoma, omitting the word leiu, just myoma. It's another name. If somebody says, I've got myoma, I've got fibromyoma, I've got fibroids, I've got leiomyoma, he means the same thing. On the picture here, we see a normal uterus and a uterus with lots of growth inside them. Those are uterus with fibroids. We'll discuss different types of fibroids. Let's start with the definition. What is the definition of fibroids? What's the definition of fibroids? Uterine fibroids or leiomyoma is a benign tumor. When we say tumor is benign, we mean it's non-cancerous. It doesn't form cancer. It's a benign tumor of the uterus smooth muscles. It's of smooth muscle origin. Uterus consists of many smooth muscles. More than 20% of African women of reproductive age are reported to have fibroids, which means these tumors are more common in Africans than in non-Africans, in whites. It is the commonest pelvic tumor in the reproductive age group, women who are still reproducing, who are still menstruating, premenopausal women. The commonest tumor of the uterus is fibroid, which means majority of women are sitting with fibroids here, asymptomatic. They don't even know that they've got fibroids. In them, they contain a large aggregation of matrix, fibrous tissue, fibrolectin, collagen, and all those tough tissues are found in fibroids. That's why they are hard tumors. And they're all derived from the smooth muscles of the uterine wall. If you look here, you see different types of sizes of fibroids. Fibroids smaller, those small ones, will hardly give you any symptoms. But the bigger they become symptomatic. And they become even more bigger than that. It depends on sizes. Sometimes women, they have symptoms and they don't treat. If it's not treated early, they can grow up to this level, find that the woman, even the shape is distorted because of the fibroids. In hysterectomy specimen, when you remove the uterus, about 7% of them will have fibroids of variable sizes. They're usually small fibroids. If they were not done, hysterectomy was not done for fibroids. So you will find that maybe it's fibroids peanut size like this, or a fibroid like this, which can either be symptomatic or asymptomatic. We'll discuss the symptoms thereafter. Sometimes there can be so multiple. And if they are multiple, probably they'll have symptoms. Either they'll give you infertility, they'll give you menstrual pains, they'll give you heavy menstruation, they'll give you pressure symptoms. We'll discuss the symptoms later. And if the woman is complaining of infertility because of fibroids, because it's one of the common causes of infertility, one sometimes is forced to remove all of them in order to increase the chances of fertility. You will find that I had to remove fibroids this many in one patient because she needs to have a baby. And the fibroids are one of the commonest causes of infertility. But majority of fibroids, they come, if they are singly, they come in solitary, big, various sizes. What is the pathology of fibroids? They, as I said, it might be one fibroid anywhere in the uterus, or there might be many, multiple fibroids scattered all over the uterus, like we have seen in this previous one. They might range from, on the fibroid, they might range from being on the cervix, on the isthmus, on the fundus of the uterus, anywhere on the uterine body, fibroids can be there. Sometimes they can project even into the uterine cavity where the baby is going to sit, competing with the baby. That's one method how they cause infertility, because if they are inside the uterine cavity, the implantation must take place inside the uterine cavity, and fibroids are large. You'll either have no pregnancy at all, you'll have repeated pregnancy losses, repeated miscarriages. More often, sometimes they may be on the surface of the uterus. If they are on the surface, they don't cause infertility, but they might just cause pain or pressure symptoms. Or sometimes may develop a stalk called peduncle, and that way they are called pedunculated fibroid. They'll just give other symptoms except infertility and heavy menstrual bleeding. Fibroids that are pedunculated do not result in menorrhagia, do not result in heavy menstrual bleeding, do not result in infertility, but may distort the shape of the uterus if they are on the wall of the uterus or inside the cavity of the uterus and interfere with fertility. If sometimes fibroid is just adjacent to the uterus in the broad ligament leaves, it is called a ligamentous fibroid. And that's a very difficult fibroid to operate because in the broad ligament, there are a lot of blood vessels there. If you have to operate on a broad ligament fibroid, you must expect a lot of torrential bleeding, and it's even more common to bleed even after surgery. But the commonest complaint of women who have got fibroid is heavy menstruation, heavy and prolonged, more than 10 days of heavy bleeding with clots. That's the commonest complaint of women in the reproductive age. And if they are big, we'll discuss the controversy thereof. As more often women, because they are asymptomatic, by the time they become symptomatic and large this size is when they come for surgery. And there's usually a cutoff line where you can remove the fibroids to preserve fertility, or you have to remove the uterus. Like, for example, if a woman comes for the first time with fibroids like the ones on the picture, and she's desiring fertility, there is no way, the chances that you can remove this fibroid and end up with a uterus which is capable of carrying a baby is zero. Such women are usually advised that they must just remove the uterus to relinquish the symptoms of the fibroids, irrespective of the number of children that she has. So it's important that women should go and check themselves up regularly to make sure that they don't have conditions that will stop them from having babies by the time they want to have babies. How do the clinical feature of fibroids? Fibroids, as I said, it goes racial. You know, in medicine, racism in medicine is allowed. You find that there are some conditions which are common in whites, and blacks will say it's more common in whites, like skin cancer. The conditions like fibroids, they are common in blacks. And when whites used to say they are common in blacks, we used to feel very offended. But it's true. Fibroids are more common in blacks than in whites. The disease profile in blacks and whites are different. Blacks have got their own disease and whites have got their own disease. More often you will see that, as I say, the presentation is usually late, and women come already late for symptoms. Sometimes you may find that a beautiful woman who used to be tiny with a flat tummy is starting to develop a tummy like she's pregnant. If a tummy is like that and she's not pregnant, chances are that there's a huge fibroid uterus there, which is distending and disfiguring this woman. That's one of the commonest things that they'll come and say, I'd rather lose the uterus than to be disfigured. So it's important that you check yourself, more especially in this July month. July is internationally a Fibroid Awareness Month. It's the month that I urge every woman, if she can afford, to go to his gynecologist and check just pelvic examination, check the uterus, check the tube, general checkup, and stay with the knowledge that you do not have fibroids. It's better to stay with the knowledge that you don't have. Those few that will get, they will have to be treated, because July all over internationally, black and white, is a Fibroid Awareness Month. It is the month that a woman should just come and say, I just want to check myself. I want a full pelvic examination. You might do abdominal ultrasound. You might include vaginal ultrasound. It might do abdominal palpation. Even if you've got no symptoms, because as I said, it's better to stay with the knowledge that you don't have fibroids rather than to stay with the knowledge that you don't have fibroid, but you have it. The cause. Unfortunately, the precise cause of fibroid is not known. Nobody knows why people develop fibroids. As we don't know why woman A develops fibroid, woman A doesn't develop. But the trend has shown epidemiological that it tends to happen in certain families. People who have got fibroids have got a first-degree relatives who also have fibroid, either the mother or the sister. So in that way, they think there is some genetic connection here. The translocation of chromosome 12 and 14 was usually blamed, but it's not proven to be the cause. And this is some fibroid, they find that chromosome 7 is deleted. But later research showed that that is not the cause of fibroid. It's just an association. You know, in diseases, there are associated factors and the cause, but the cause is not known. Estrogen does play a role in the existence of the fibroid because as fibroids are estrogen sensitive. That's why women in the reproductive age who have got a high estrogen level, they've got fibroids growing very fast. After menopause, the estrogen level goes down, the fibroids ceases growing, but they never disappear, they just stop growing. There might be other chemicals that are yet to be found, which might be involved in the causation of fibroid. But at the moment, we don't know what caused these tumors. And we don't know what make them to be so varied and proliferate in such a different shape that they can grow anywhere and distort the shape of the uterus such that the cavity of the uterus cannot carry a baby. That's how it affects the pregnancy. They have done so many studies in fibroid etiology that there are more than 100 genes were found to be up or down regulating the fibroids, and that has not proven to be the cause of fibroids. Those genes that they found are normal genes that regulate cell growth and proliferation in other cells also. So because fibroids don't develop in other cells also where those genes are applied, that cannot be said to be the cause of fibroid. But initially when they discovered, they thought this would be the cause. The difference between fibroids, which is leiomyoma, and leiomyosarcoma, it results from malignant changes in fibroid. Fibroid sometimes can change into malignancy. Very rarely they become, they are not fibroid malignant, but they can metamorphose into a type of tumor, which is called fibromyosarcoma, which is a connective tissue tumor, which also has got fibrous tissues, but is malignant. But very rarely fibroids are malignant. If they are becoming malignant, really, they are not very aggressively malignant. Usually, they don't metastasize early. So once they become malignant, there'll be heavy menstrual bleeding. And if we operate, hysterectomy alone can cure fibromyosarcoma. So the risk factor, as we said, to recapitulate, is the heredity as it runs in family. It is starting race. Which race? The black race. Nulliparity. Nulliparity means a person who doesn't have a baby, no parents. There's a saying that bad girls get babies and good girls get fibroids. This was a saying because usually good girls are those who don't have children. They develop fibroid, but that is just a saying in obstetrics and gynecology. But usually it doesn't mean that if you don't have a child, you develop fibroids. It means that the fibroid causes people not to have children because fibroid causes infertility. And usually it's associated with fat. You know, people who are obese, they usually have fibroids. And people who are on oral contraceptive are associated with fibroid because those are the people that are nulliparous. And by the time they stop oral contraceptives, they end up with the problem of infertility from fibroids, and they blame the contraceptives. If they develop into fibromyosarcoma, they can cause loss of weight, excessive loss of weight on the other part, and abdominal distension, because fibroids that causes leiomyosarcoma are usually huge fibroids that will distend the abdomen, but the person will lose weight. But normally fibroids, because they are not malignant, they don't cause loss of weight. They just cause a big tumor. It can go as big as this one with distended abdomen, but no loss of weight. Once there's loss of weight, there is malignancy underlying those fibroids. They are classified in this way. If the fibroids usually is on the body of the uterus, if the fibroids are inside the wall of the uterus, on the wall of the uterus, on the body, it's called intramural fibroids. They are called intramural fibroids. If they are on the wall, but on the where the fallopian tube enters the uterus, where the egg is supposed to enter the uterus, where the sperm is supposed to exit the uterus, if they are there, they are called interstitial fibroids. And those are the fibroids that will block the tube because they are on the entry of the tube. They are called interstitial fibroid. A person with interstitial fibroid will have blocked fallopian tubes, thus will have infertility. If they are on the surface, just beneath the surface epithelium of the uterus, which is called serosa, they are called subserosal surface. And if they are just inside the uterus, just beneath the endometrium, beneath the layer that the woman bleeds every month, they are called submucous fibroid because the endometrium is a mucus epithelium, mucus secreting epithelium. Both submucous fibroid and subserous fibroid can develop a stalk. If they develop a stalk is called a peduncle. They are called pedunculated fibroid. Very rarely they can develop on the cervix and thus interfere with sperm entry into the uterus, or it causes repeated pregnancy loss from cervical incompetence. They are called cervical fibroids. Cervical fibroids are very rare, but they can occur. The commonest fibroids are the ones on the body of the wall of the uterus, which are called intramural fibroids, which distort the shape of the uterus like the previous one that we see. And in that way, as the uterus grows, they increase the surface area of the endometrial activity. If the surface area increases, the amount of blood that will be lost to menstruation increases, and the duration of menstruation increases. That's why a person has got heavy bleeding for a long time. If he used to bleed for 4 days, now he bleeds for 10, 11 days, heavy with clots. And if they are nearly fill the pelvic cavity, they will compress the bladder, and the urinary bladder will have no place to distend when it's filled with urine. So you'll go to the toilet more frequently because the bladder has got no place to expand and store a lot of urine. So this bladder stores less urine. A woman with huge fibroids goes to toilets more often because of lack of bladder compliance, because the fibroid is occupying the whole pelvic area. As I said, it increases the chances of this intramural, most especially interstitial. They cause infertility or subfertility or repeated pregnancy losses in the form of early miscarriage before 3 months. Like if you have a fibroid like this and an implantation takes place in a small uterine cavity there, as the baby grows, there's no place for the baby to grow. The whole area is occupied by the fibroid. So the best is just that baby will be aborted. The same as this one. This one you can see is also submucous fibroid here. It will cause heavy lot of bleeding. So this one will cause menorrhagia, heavy prolonged bleeding, and infertility. If they compress the ureter, because sometimes they go up to the wall of the pelvis and compress the ureter. The ureters are the tubes that drains the urine from the kidney up to the bladder. If they compress it, they block it externally. The ureter will distend because urine will pack up there and distend the ureter because the whole area is occupied by a fibroid, and that will cause hydronephrosis, hydroureter. It can even result in renal damage and damage the kidney. This is the picture that I show that If a fibroid compresses the urinary bladder has got no place to expand to go to fill up urine. So little urine, as little as 200 to 150 mils, the bladder will feel like it's full, and you'll go to the toilet more frequent than others because can't store a lot of urine. These are the submural, intramural fibroids, which are the commonest ones, like this one that we see here. They're all intramural, and they can go very big. And you can see the uterine wall is very little here. The whole uterus is occupied by the fibroids. These are several intramural fibroids, which has got several intramural fibroids, which one fibroid inside the cavity, which is a submucous fibroid. This is what a submucous fibroid is, inside the cavity. Let me do something. These are the submucous fibroid. This is a fibroid in the wall of the uterus, intramural fibroid, with a cavity here, lot of bleeding, menorrhagia. This is a cervical fibroid that I said. It causes infertility by causing what you call cervical incompetence, or it might just close the cervix altogether and prohibit sperm entry into the uterus, that causing infertility. If it's protruding there, it can cause bleeding during sex. In that way, anytime bleeding during sex, one would suspect cervical cancer. After excluding cervical cancer on speculum examination, you might find a polypoid lesion there, which is a fibroid. But always when there's a bleeding during sex, expects cervical cancer. This is a fibroid that has degenerated. It has liquefied because it has outgrown its blood supply. We'll talk about degeneration later. Let's talk about a polypoid fibroid. A polypoid fibroid, usually it might be a submucous fibroid that has developed a stalk, pedungulated fibroid, but it goes and protrudes through the cervix and fill up the vagina. And you'll find that there's a mass in the vagina, which is more often very smelly, foul smelling, or can be bleeding. And commonly it just becomes foul smelling. And inability to go intimate, because sometimes it fills the whole vaginal cavity. So they will not be able to, woman cannot go intimate because there's no place where the man can go. In that case, the first thing, if you've got these signs above, exclude cervical cancer. And more often, when you do a speculum examination, you find a mass protruding from the cervix. It can be of any size, and that will be a fibroid protruding from the cervix, which is called a polypoid fibroid. Sometimes they call it cervical polypoid fibroid. Like we see here, this fibroid tumor, there are multiple fibroids, intramural, and one submucous, which is pedungulated here. But this one, the peduncle went through the cervix and it protrudes into the vagina. That's a polypoid fibroid tumor. It can grow very large. I find, I don't know, because if you find a woman with a large polypoid tumor, polypoid fibroid tumor protruding through the cervix, if it's large, very large, you must know that it's more than 4 or 5 years that is there. The woman has been delaying. But lack of knowledge, it was make women to delay to seek help or to seek proper help. That's why, hence, I make these webinars as wake-up calls for you women that this month, go and check yourself. The fibroid that I said in classification, that if they develop on the between the walls of the broad ligament, they are called, let me see if I can see who is talking. I've made my things here. I can't see who is talking. Okay, I'll see who is talking later. Don't worry. Mahapa, please mute yourself. The ligamentous fiber, the one that I said, Mahapa, please mute yourself. I can't mute you. The only thing that I can do, I can remove you, but I don't want to remove people. Ligamentous fibroid, I said, they develop between the leaves of the broad ligament. And those are very dangerous fibroids because between the leaves of the broad ligaments run a lot of the vessels that supplies the uterus with blood. They run there and they supply this fibroid. It bleeds a lot if you have to operate it there. Those are the type of fibroids that they bleed. If they bleed a lot, you might go to surgery, go to operation, hoping that you are going to do an operation for removal of fibroid and end up the doctor being forced to remove your uterus because of the bleed that can occur in ligamentous fibroid, which are extrauterine. You don't wish to have that. But it's not always that they will be that. These are the ligamentous fibroid on the broad, between the leaves of the broad ligament. They're outside the uterus, but they're supplied with a lot of blood vessels. And when you operate here, bleeding can be so severe that one may end up removing the entire uterus in order to arrest the bleeding. What is the pathology of the fibroid? This is a well-circumscribed tumor with a pseudocapsule. They don't have a true capsule. It's a pseudocapsule, an areolar tissue capsule that is formed by compression of the fibroid against the uterine smooth muscle. They form a false capsule there, which is a connective tissue which fixes the tumor to the body of the uterus. The blood supply to this tumor lies in that pseudocapsule. Hence, when you operate, you shell it from the pseudocapsule. And as we shell it from the pseudocapsule, that's when bleeding comes in. Because one of the notoriety of fibroids is that myomectomy, removal of fibroids, can bleed a lot. And it can bleed primarily. As you are operating, it starts bleeding a lot. That is that you can even have to transfuse blood to the patient. Or the worst is if it undergoes secondary bleeding. Secondary bleeding is bleeding occurring after 24 hours after operation. You operate the patient today, it's fine, you arrest the bleeding, you leave it in the ward. Tomorrow, she starts dropping HB, she starts bleeding again. That's a secondary bleeding. So when doing myomectomy, one should make sure that you arrest bleeding, make sure that hemostasis is maintained completely. And the patient who post myomectomy must be watch like a hawk for secondary bleeding. By the time you get discharged, you must make sure that the ultrasound, there's no sign of bleeding. HB is not drawn because it has got a tendency of bleeding even after some days after surgery. This is sometimes fibroids, if they are submucous and polypoid, you can remove them through a hysteroscope. Hysteroscope, you look it through the cervix, and with a snare or with a cautery, you can shave it and remove it. This is good for small fibroid, not for big fibroid. For big fibroids like this, myomectomy and surgery is the treatment of choice. The fibroids, as you look here, got a lot of fibrous tissues inside, even outside and inside. If they become big, like this one, this is only one fibroid. They usually in the center, the blood supply in the center becomes less, which means they've outgrown their blood supply and they undergo changes, which is called degeneration. And we'll explain degeneration. Degeneration is one of the complications of fibroids, and some degeneration can be very painful. If our fibroids are looked through the microscope, they see a lot of different varying planes of cells separated by fibrous glands. These are the type of smooth muscle cells that are on the slide of fibroid with dark nuclei, spindle-shaped smooth muscle cells, which sometimes can become concentric smooth muscle cells with tapered nuclei, which is stained pink, but not malignant. They are no mitotic features, which means they are not malignant. And sometimes degeneration that I talked about, which I said one of the complications of fibroids, if they outgrow their blood supply, they can undergo degenerative changes. And the degenerative changes that the fibroids can undergo includes hyaline degenerations. The commonest degeneration is what we call hyaline degeneration. Hyaline degeneration, there's a lot of hyaline deposit on the fibroids, and they become soft and painful. Sometimes, like the previous slide that we've seen, the center, as it outgrows the blood supply, it liquefies, becomes liquid. And on palpation, you find that it becomes soft and not hard. That is called cystic degeneration. One can do an ultrasound and find a cystic structure there and even confuse it for an ovarian cyst, only to find that it's a fibroid that has degenerated, undergone cystic degeneration. Now it's no more hard, it's fluid. Sometimes, if they are old enough, long enough, they can deposit a lot of calcium. The picture that we see here on the screen is calcified fibroid. It's calcific degeneration. Calcific degenerated fibroid don't grow, they don't regress, they usually don't cause much pain because they are dead fibroids. And sometimes they can undergo fatty changes and become fat. A lot of fat cells deposit in the fibroid and it's called fatty degeneration. During pregnancy, one of the commonest causes of acute abdominal pain in pregnancy is fibroid degeneration. It's so painful that no patient can stand that pain. We can even confuse it for appendix. It's not uncommon to operate a patient, for a doctor to operate on a pregnant patient thinking that she has got appendicitis, only to find that she has got a red degeneration of fibroid, a condition called necrobiosis or cutaneous degeneration. It's usually called red degeneration because it's red in color. If there's infection and a degeneration happened during infection, it can become suppurative and become septic degeneration. In that way, it's also a medical emergency because it can lead to septic shock, is septic degeneration. We talked about the commonest one, which is hyaline degeneration, which is a process of tissue replacement where the fibrous tissue is being replaced by a hyaline, or a tissue has generated into hyaline. The fibroid tissue has degenerated into hyaline. Is the mildest, the most common of degeneration, occurring up to 65% of women. It doesn't cause pain. You know, the good Lord is very good. Things that are more common are not much dangerous, are not painful. The smooth muscle of the myoma are just replaced by connective tissue. There's no pain, there's nothing, but it's the commonest one. The uncommon ones, they're the ones that give you pain, like red degeneration. This is the slide of hyaline. The whole area here is hyaline all over. And on microscopy, you can see it's not as white as fibrous tissue that you have seen. If you compare the fibroid, normal fibroid with whitish fibrous tissue, and the one that is hyalinized and is yellowish, whitish, creamy, soft, hyalinized fibroid. You can even see it on microscopy. This hyaline is soft on consistency, but this one is hard on consistency if it hasn't. The red degeneration I said is the commonest one. It's necrobiosis, is found in pregnancy. Sometimes it's called cutaneous degeneration. The word red degeneration, the word cutaneous degeneration, the word necrobiosis means the same thing. It occurs mostly during pregnancy, but are rare. And if it occurs, it really becomes a really painful condition. And on microscopy, if you see it, it differs from the hyaline degeneration. It's reddish. You can see that it's got a lot of hemosiderin deposit and blood inside. Even on microscopy, the nuclei are dark, are large. There's increased nuclear cytoplasmic ratio, but there are no mitotic figures. There are no, with mitotic figures, we suspect malignancy. These are just benign tumors. You compare the red degenerated fibroid and normal fibroid, which is not degenerated. On naked eye, you can see that this is a red degenerated fibroid, which is common in pregnancy. As a calcified fibroid, there's calcium deposit in them and the fibroid tissue. It's usually the result of aging. Old, very old fibroid. You find them in very old people. If a person has got a calcified fibroid, you must know that fibroid has been there for over 20 years in that person, not been treated. And as time goes on, they outgrow the blood supply, they're deprived of oxygen, and they calcify. And sometimes they shrink a little bit, but they do not disappear. Like we can see these fibroids, they are all calcific degeneration. This probably is an old woman who has a fibroid for many, many years, and probably this one was infertile. You can even, because calcium is also found in bones and other things. Or if you do an X-ray, you can see them on an X-ray. But a normal fibroid, which is not calcified, you can't see them on an X-ray. But on X-ray, you see a mass in the pelvis, a huge mass in the pelvis. That will be a calcified fibroid, which is incidentally seen. This is the picture of a calcified fibroid as seen. And at the close-up view or thereof is this one. The whole thing is hard, it's like a stone. It's hard like a stone. The cystic degeneration, I've said that the center, if it's deprived or it outgrows the blood supply, it liquefies and forms liquid. And that liquefaction is called cystic degeneration. It's not uncommon to find an area of cystic degeneration and area of hyaline degeneration in the same fibroid, which is myxoid degeneration. Sometimes calcification that occurs there is dystrophic calcification, which occurs in very old fibroid. This is a cystic degenerated fibroid. You can see that there's even bleeding inside this fluid, which occurs in here. The cervical fibroid, I said they are very rare. The presentation of them can be vaginal bleeding, usually during sex or after sex. And if there's vaginal bleeding during sex or after sex, the first thing that could come into your mind is not cervical fibroid, it's cervical cancer. Sometimes, more often, they prolapse and present as prolapsed fibroid. And because they're in the vagina with all the bacteria in the vagina, they become easily infected and smell easily and bleed easily. And as they become infected, they make a very bad vaginal discharge, very foul smelling vaginal discharge. Even the woman herself can feel that I'm smelling very bad. If they are very large and go upward on the anterior vaginal wall and block the urethra, so they block the urethra, they can cause urinary retention, or they can just disturb the uretrovesical ankle and cause urinary incontinence. But they are very rare, those type of fibroids. The good Lord is not so cruel. He doesn't make things like that. In the managed, this is a cervical fibroid. This picture is cervical fibroid, which is treated by embolization. They put a catheter inside the vessel that supply the fibroid and inject beads here that will clot here and block the blood supply to the fibroid so that the fibroid must not grow. But that way, you might cause a problem. You might cause degeneration. You might cause atrophy. You might cause dystrophy of the fibroid, but it will not grow, one thing for sure. What can happen to fibroids? Like cervical fibroid, which is protruded into the vagina, can be infected and found very smelly. It can atrophy if the blood flow to the fibroid is blocked, and necrosis. Necrosis means die. Or it may have a lot of blood vessels like the interstitial fibroid and the broad ligament fibroid. The worst that can happen if it undergoes sarcomatous changes and start to become malignant, like this sarcomatous fibroid here. We don't wish that to happen. Luckily, it's very rare. As I said, majority of fibroid, over 80%, have got no symptoms. The only symptoms that you can have with fibroid is heavy, prolonged menstrual bleeding, which is called menorrhagia, or irregular menstruation. So irregular that it's said to be irregularly irregular. You don't know when to menstruate. Anytime you can menstruate. There's no the rhythm of menstruation. You must always have pads with you. You can go to the mall and menstruate. Yesterday you were not, tomorrow you are. After 3 weeks, you irregular menstruation. It's called metrorrhagia. And pressure symptoms, which like frequency of micturition, painful sex, and urinary retention. Dysmenorrhea, painful menstruation, usually, it does happen with fibroid, but usually it's a common feature of adenomyosis and endometriosis, which they usually coexist, this condition. Of course, most women who come for myomectomy because of fertility or subfertility, or repeated pregnancy, or repeated miscarriages, repeated early trimester miscarriage. She never conceived more than 3 months. Two months miscarriage, 3 months miscarriage, 2 months miscarriage, early miscarriages. These are the cause of by fibroids, usually which occupy this area where the baby is supposed to be, which is the cavity of the uterus, which are the submucous fibroids, like this one here. It occupies the whole area where the baby is supposed to be in the uterus. So once the fertilization can take place, the pregnancy test will be positive. But after 12 weeks or 14 weeks, the pregnancy disappear. The shape of the human being, a woman is not only a reproductive animal. The shape of the woman, the body, the beauty is what the woman is proud of. One of the things that the woman will consult, will go on diet and everything, is change in body shape. Once you've got a woman who has got a wardrobe that fits her very well, suddenly she develops a tummy. And she doesn't gain much weight. She tried to be on diet, but the tummy keeps on growing. She's not pregnant. And she has been looking after a mirror, and it was a flat lady with stomach outs. Now she starts to have lebutzanayana. So it's because of the fibroid which has grown more than 12 weeks, equivalent to 12 weeks pregnancy size. Now it's becoming abdominal, and she is now starting to realize that as she measures herself, the waist or the girth is increasing every 6 months. You find that she's gaining the abdominal circumference because of large tumors that are in there. It's better to be examined and get what the cause is. If the cause is large tumors, fibroids, remove them. I have seen a woman. This is the woman that the largest fibroid that I've ever seen. And I think it is I'm boasting that it's the largest fibroid that have ever been done in South Africa and was done by me. This is a woman. It's from here in Limpopo. But I did that when I was still in Pretoria, but she's from here in Limpopo. She came to me, she couldn't walk the way the fibroid was so heavy. And the story is just pathetic. She's been moving from doctor to doctor with some people even told her that you are not going to live. This is cancer. And we operated her. During the operation, we removed a tumor this size, one big fibroid. This old woman could not walk. She was about 68 years, and it filled up the whole dish. We had to get extra assistant, sister to scrub, to help us take it out of the human body. And the weight of the uterus of the fibroid uterus after removed, it was 13.2 kilograms. This woman could not walk with a 13.2 kilogram. And this is I call that the largest fibroid. I even published it in a journal. If you just go to Google and type the word, the largest fibroids, Dr. D.T. Mahapa, it takes you directly to that journal, OBGYN journal, and you'll read more details about how this woman came about, what kind of tissue we have, clinical pictures, how did we manage it. And she walked immediately after operation. As she started to walk, she was 70. It's like she would fall. We have to get a tripod for her to walk. But after sometimes she gained equilibrium. Just right here, the largest fibroid, Dr. D.T. Mahapa. Just in Google, it will take you to that journal. The journal's name is OBGYN. It's an American journal. The relationship between fibroid and fertility is very common. You must go into it. Fibroid may interfere with sperm entry into the uterus, more especially if they are next to the cervix. They may just block the cervix. Sperm don't enter there. If they are in the interstitial portion of the tube, they might compress the tube and block the tube. These are the commonest. That's why I say people with interstitial fibroids have got blocked tubes. If they might interfere with implantation, nidation, fertilization might take place. But when implantation is supposed to take place in the uterus, the place where the implantation must take place might be occupied by a fibroid, that causing infertility or early pregnancy loss. That way, the woman keeps on aborting or miscarrying early, 2-3 months she miscarry, 2-3 months she miscarry. He moves all around. He goes to Inyangas, go to churches, blame all the relatives, but the cause is fibroids. But the rule is this one. If fibroids is less than the size of the uterus is less than 12 weeks pregnant uterus, which means it's still inside the pelvis and it's got fibroids. Myomectomy improves fertility because those are small myomas, small uterus. But if the fibroid, the large myomatous uterus, is equivalent to 13 weeks pregnant size or more than 13 weeks pregnant size, myomectomy, even if we remove fibroids, does not, it's proven that it does not improve fertility as such. You can just do it, because for the patient's sake, but the chances of fertility, they decline as the size of the fibroid increases. So in large fibroids, we'll find that the fibroid size is equivalent to about, the uterus is like equivalent to 18 to 20 weeks pregnant size. And that patient should be advised to remove a uterus, irrespective of whether she's got a child or not, because there's no chance that you can improve fertility in such a woman because the fibroid has totally destroyed the uterus. The controversy will be fibroids in a young woman, small fibroids in a young woman who is not preparing to have a baby. What do you do? Because fibroids, they are small, but this woman is not desiring a baby, and they are not symptomatic, it's not amenorrhagia. But if by the time she wants to have a baby, this fibroid might be big and cause infertility, what do you do? Some people will say, I'll follow it up. When she's just about to have pregnancy, I'll remove them. I say, by the time she decides to have pregnancy after 4 or 5 years, the fibroid might be so big that they warrant hysterectomy. I think my opinion is not, this is why I say it's controversial. Literature says different things, but I buy this one. If there are fibroids in the uterus, submucous, and I know submucous fibroids are very notorious of causing infertility. In any woman, irrespective of whether she desires to have pregnancy, I'll advise the woman to remove the fibroid and abandon the idea of postponing pregnancy and fall pregnant. That's what I'll advise, irrespective of whether she's got a steady boyfriend or not, and tell her, look, you are a fibroid former. Because fibroid former will always form fibroid. Because if she says, I'll have pregnancy after I finish my master's, and she's still doing course 1, or after I found a steady boyfriend, which you don't know what a steady boyfriend, when you'll find it, maybe you'll never find it because nobody's steady here. By the time she realizes that the fibroid might be this size, and now, as I said, indication that is to remove the uterus. I think it's better to have a child out of wedlock and not be married and have a child, have a single mother, than to be a qualified somebody with PhD, but without a child. That is controversial, but you have to talk to the patient and show him the pros and cons, because fibroid this size, small, will not cause much problem, but if you leave them long, they might cause problem with fertility. That way, we might have just to remove the uterus. And by the time, there might not be only be one fibroid, there might be many. And when fibroids are many and big, if we examine abdominally, you feel this hard nodular mobile uterus, which is not soft, it's nodular. If there's degeneration, there will be solid area, hard areas, and soft areas. And the margins of the uterus with fibroid are well defined. You can feel that it ends here. Unlike if it's cancer of the uterus, you can't feel the margin. It's matted all over. And the mobility, how mobile it is. You can't move it from feet to the head, upside down, but you can move it easily side to side. And when you percuss over it, unlike in abdominal intestinal obstruction, is dull, dull. And because the blood flow to them is not so, although it's a lot of blood supply, it doesn't give a bruit like malignant tumors of the ovaries. This is what you can feel on examination of fibroid. This nodular fibroid uterus, which has got nodules on them, which can even palpate them if the woman is thin-skinned. And on examination, of course, you'll find that irregularly enlarged uterus, and you cannot feel a uterus separate from the swelling. The swelling or the nodules are part of the uterus, and we do bimanual examination. The cervix move with the fibroids. This is a normal uterus, If we do bimanual examination, the other hand can feel the uterus on the fundus, other hand is in the cervix. But if you do a bimanual examination in a patient with fibroids, you can feel this hand will feel this nodularity in here. And if we move it side by side, the cervix will move with the uterus to show that that tumor is part of the uterus. The best diagnosis that is done these days is by abdominal ultrasound or transvaginal ultrasound. Laparoscopy is rarely needed. It's only needed if you want to do laparoscopic myomectomy. For small submucous fibroids, which are inside the uterus, hysteroscope might be the tool that you can use to diagnose and even treat with hysteroscopically directed myomectomy. With transvaginal sonar, you can see the uterus, a pear-shaped structure, but it's got a well-circumscribed tumor here, which is in that way, it interferes with the cavity of the uterus, which means it's submucous fibroid. Sometimes it can be away from, this is the cavity of the uterus, away from the cavity. This is intramural fibroid. The difference between intramural fibroid and submucous is that submucous, it interferes with the uterine cavity. The intramural is away from the uterine cavity, but it increases the surface area of bleeding that it causes menorrhagia. Very rarely, sometimes, not really, it's not the commonest cause of early pregnancy loss, unless if implantation takes place on top of the fibroid, which rarely does that because that area is not favorable. With a hysteroscope, where you inject a saline inside the fibroid, you can see a submucous fibroid very easily and treat it with a hysteroscope. Yeah, this is a submucous fibroid on transverse section with a hysteroscope is treatable. But if it's large, it might need a laparotomy. This is a submucous fibroid that we've seen through the sonar. This is submucous fibroid, which has got a stalk pedunculated. This one is submucous, not pedunculated. Subserosal, not pedunculated. Subserosal, pedunculated. Intramural fibroid. Intramural ligamental fibroid, cervical fibroid. These are the type classified, all of them depicted in one picture. How do you manage the fibroid? If they are asymptomatic, the management is don't jump on it. Observe what they'll do. If a woman has finished childbirth, is approaching menopause, it's worse. You just, okay, stay with them. They won't kill you. Very rarely they develop myosarcoma. We know that after menopause, they're not going to grow. But the problem is if he's young. If he's young, as I've said, that treat them because they are going to grow. They're estrogen sensitive. What do you do with fibroid in a woman who wants to be pregnant? Is expecting to have pregnancy, the serious of being pregnant. If there's been 12 months of unprotected sex, or there's been a history of repeated pregnancy loss, remove the fibroid. What do you do with fibroid approaching menopause? As I said, expectant management. If they don't give menorrhagia, they don't give pain, approaching menopause, she's not desiring any children, just leave them as they are. After menopause, they won't grow. Unless if they've got other symptoms like abdominal distension and it disturbs, so you can remove the uterus in that case. Surgery for a large fibroid remote from menopause. If menopause is far and the fibroid is large, the treatment is surgery. And the type of surgery depends on the number of fibroids and the size of the uterus. If it's huge, more than 13 weeks, equivalent to more than 13 weeks pregnant uterus, remove the uterus. If it's small, remove the fibroids, myomectomy. The smaller the tumor, the less the complicated the surgery. But the bigger the tumor, the more the complicated. Because patients with large tumors, large myomas, myomectomy, you might go through the operation hoping that you're going to remove the fibroid and only be forced to remove the entire uterus because of bleeding. It bleeds a lot. What do you do with symptomatic fibroids? There's medical control of symptoms, like pain, you can control with medicine. There are some medicines like gonadotropin release hormone agonists, Zoladex. They can shrink the fibroids, but they don't make it disappear. Don't be given Zoladex, think the fibroid will disappear. It will just shrink. That's why medical treatment is just neoadjuvant to shrink the fibroid so that the blood flow, the blood supply to the fibroid can be diminished and make surgery easier. Surgery must not bleed. There's some fibroids that can be destroyed by ultrasonic, but those are very small fibroids, not large fibroid. If it's large fibroids, myomectomy, removal of fibroids through a laparotomy or through laparoscope is the treatment of choice. Radiofrequency ablation is also done in rich countries, but for a very small submucous fibroid. If the patient is bleeding a lot and has got anemia, you treat anemia. Is that you treat anemia with hematinics or you treat anemia by blood transfusion, but make sure that the patient is no longer anemic. You treat anemia. Nowadays, with radiological intervention, you can embolize the fibroid, the blood supply. You identify the vessel that supplies the fibroid with blood and embolize them. You block them so that they mustn't be supplied with blood and they will die. That is what you call embolization of fibroid. It's done by the interventional radiologists together with gynecologists. It's a radiological management of fibroid. Like this fibroid here, intramural fibroid. This is the blood vessel that supplies the fibroid. They go with a catheter here and inject the beads here that will form a gel here and clot this fibroid. Blood flow will never go to the fibroid. That needs a very good interventional radiologist. But majority of fibroid that we see in African population, they just need laparotomy. And with a scalpel, you cut, remove the fibroid, remain with the uterus, which the fibroid has been removed here. Tricky. I've said the fibroids have got a pseudocapsule, and in the pseudocapsule run a lot of blood vessels that supply the capsule. After removing this fibroid, you need to close this dead space completely because it can accumulate blood. That's the cause of secondary bleeding. In a patient that when in theater, the surgeon closes, nothing is happening, she's not bleeding. 2-3 days in the ward, she starts bleeding. If that area is not well obliterated, you must put stitches inside and outside and compress. No vessel must bleed because this might be tiny vessel that you might not see with naked eye, but they can accumulate blood over some times and start bleeding such that the patient will collapse 2-3 days thereafter. But you have just removed a fibroid like this one, and you find that now you wonder why the patient who was well day 1, day 2 is now collapsing because of bleeding. The oral contraceptives must be progesterone only. They can just delay the growth of fibroids and control the bleeding. Symptomatic management. Same as GnRH agonists. GnRH agonists, what they do, they block the gonadotropin from the higher center, from the hypothalamus, and cause amenorrhea. You don't menstruate at all because now it's symptomatic management. You're treating the heavy bleeding, so you're stopping the bleeding, but the fibroids are still there, so you're not treating the fibroids. The same as danazol and RU486. They just stop the bleeding. Antifibrinolytic agents are agents that increase blood to clot. But if it's due to fibroid, there's very little place for tranexamic acid or antifibrinolytic agent because they will make the blood to clot inside the uterus. If you have got heavy bleeding, it will be heavy bleeding with clots. And NSAIDs, non-steroidal anti-inflammatory drugs. Jona is for pain. These are painkillers. NSAIDs are painkillers. If the fibroids have degenerated and cause pain, you can give that. But the mainstay is myomectomy if they are less than 12 weeks or hysterectomy. If fibroids this shape, the best plan, there are many everywhere, submucous, subserous. If the patient has got a fibroid this size, this big, you've got a choice. If it's less than 12 weeks, you can do myomectomy. If it's more than 12 weeks, you do hysterectomy. But if it's more than 12 weeks size, there's still a uterine wall enough that you can retain, and maybe by luck you can have 1 or 2 children. And I must say that once you have had myomectomy and the uterine cavity has been entered, the mode of delivery will always be by cesarean section. There's no place for trial of scalp. I'll discuss that later. But in this case, we have said that if the uterus is so big and distended and the fibroid is such big like this, there's no place for myomectomy, for removal of fibroid. You just do a hysterectomy. This is the picture showing uterine artery embolization, where you embolize the artery that supplies the uterus, that supplies the fibroid, and the fibroids will die. In that way, you're not only making the fibroid ischemic, you're making also the uterus ischemic. So you're also interfering with fertility. So it's not a treatment that you can do for a woman who wants to have a baby. You do for a woman who doesn't want symptom of fibroid like pain and heavy bleeding. But if she's got fertility, she wants fertility, removal of fibroids is the treatment of choice. But majority of women, when they've got fibroids and they are afraid of surgery, they've completed their family, uterine artery embolization is the treatment of choice. The complication of fibroids, I've said, is bleeding and secondary bleeding. I'm saying after surgery, 2-3 days after surgery, 2-3 days in the ward, she's not bleeding. On the 4th day, when you say you're going to discharge her, she starts bleeding. That's why I said that cavity must be obliterated very strictly and monitor the HB. Then after that, there's no drop in HB. The scar where you have made the cut the uterus might cause adhesions with other organs, intestines and omentum might add to that. And adhesions can interfere with fertility. So myomectomy itself may precipitate infertility. If pregnant, I've said that once you have done myomectomy, removal of fibroid, delivery is by cesarean section, because that scar that formed there, it tends to break. They call it dehiscence. It breaks easily. And if the fibroid has got a stalk, pedunculated fibroid, it can twist. If it twists around it, it is called torsion. Cause acute pain, sudden acute pain. The woman can be operated because it's just sudden and it's very strong pain. Somebody is talking. Who is talking? Joey? Joey, mute, please. Joey, mute. Thank you, Joey. Where do I go now? I want to go there. Right. It's fibroid in pregnancy. You have got a woman with a period of amenorrhea, she has missed a period, you do an ultrasound, you see a huge fibroid, but there's a baby sitting to it there. Why do you tell that woman? That's where prayer works, you know. People think prayers don't work. Here, you've got a large fibroid, even bigger than the baby, but the baby implanted on the other wall, not where the fibroid is. You continue that pregnancy. The only worst that can happen can be red degeneration or miscarriage. If it becomes miscarriage, it's not become miscarriage, it becomes preterm labor. She will go into labor before 9 months. If she goes into labor at 8 months, 7 months, that will be a reasonable premature baby. But because there's going to be competition with the space here, this pregnancy don't reach 9 months. These are pregnant with fibroid and pregnancy. The schematic presentation, you've got a baby, you've got a fibroid. They'll compete for space here. And as the uterus enlarges, the area where there's a fibroid, it doesn't expand. So that's where you say we continue with pregnancy conservatively and expectantly and be prepared to deliver a better premature baby. It's better if the pregnancy can go above 34 weeks, but it rarely goes up to 40 weeks, and we can deliver. If the fibroid does not obstruct the pathway to the cervix, she can deliver vaginally. If the fibroid is low-lying like this one, cesarean section is the treatment of choice. After myomectomy, I want to stress. If the fibroid is obstructing the presenting part, it's not obstructing the presenting part of the cervix. I said normal vaginal delivery. And because after delivery, the uterus must contract and block all the blood flow. Because at the area of the fibroid, there's no contraction of the uterus. These women present with postpartum hemorrhage after delivery. Find that she's delivered, but she doesn't stop bleeding. It sometimes can be bleed so much that it may be forced to go into hysterectomy because now she's not stopping the bleeding. After myomectomy, how you manage the delivery, I said, is controversial. Majority will do cesarean section. But the proponent of what you call VBAC, there's a phenomenon of vaginal birth after cesarean section. Because if the scar is well healed after Caesar without infection, that scar is strong enough. You can do trial of scar. Though they extrapolated that theory into myoma to say, if myoma, which the stitching was done not in pregnancy, has healed without infection, you can also do a trial of scar. But the catch is here. The VBAC is done only on the uterus that was cut on the lower segment. So, which means myoma also must have been on the lower segment. But in an pregnant uterus, you don't see well where the lower segment starts, where the lower segment doesn't start. So, trial of scar in post-myomectomy is risky. I think it's just for the journal. The best way is to do cesarean section. Some people will say, what kind of Caesar? Because cesarean section in myomectomy has got a controversy, is very notorious of bleeding, that we can be forced to do hysterectomy because it doesn't stop bleeding. Yes, we accept. Then we're going to say, can you just electively say, I'm going to do cesarean hysterectomy, I'm going to do a Caesar in this baby and remove the uterus? You plan to do that? The answer is no, you don't. You only do hysterectomy when there's an indication, when you encounter problem. Fibroids and menopause. After menopause, fibroid regresses and reduces in size. You must know that after menopause, they don't grow, but they never disappear, but they just don't grow. The symptoms will depend on premenopausal symptoms. If you have pressure symptoms, you still have pressure symptoms. If you have urinary symptoms, you still have urinary symptoms, but symptoms like heavy bleeding and pain are very rare after menopause. Calcified fibroid, of course, is a dead fibroid. It doesn't grow. It'll just remain there. It just be a space-occupying lesion. If your fibroid grow after menopause, it is suggestive of malignant transformation. That fibroid is now becoming malignant. It's not my fibroid, it's fibromyosarcoma, and it needs urgent treatment. I've said that fibromyosarcoma is a malignant tumor, but metastasis very late, such that the management with hysterectomy is found early will be enough to treat it. Patient on RHT. Patient who are on RHT, hormone replacement therapy, will behave like premenopausal women. They will increase the size of fibroids. After menopause, we usually put the women on HRT, hormone replacement therapy. The size of the fibroids increases. And some HRT, women come to me after I put them on HRT. They start to menstruate again. I tell them, yes, I'm making you young. You're behaving physiologically like a young person, but she won't fall pregnant, but she will start physiologically to have menstruation again. So if we are on HRT, the fibroid will increase in size. As I've said that, if a patient is got fibroid and you are going to do a cesarean section or plan very clearly. The incision must be wide enough and make sure that when you cut away from where the fibroid is, because to avoid that torrential bleeding. Do not remove the fibroid. We don't remove the fibroid during cesarean section because that can cause a hell of a lot of bleeding. You just make sure that you make a wide incision and the incision must be removed from where the fibroid is. Once you have done your incision, and you're aware that now I've entered the uterine cavity, you take out the baby and close. And more often the baby is stuck there because the assistant has to push because the fibroid sometimes is on the way of the baby. After you've removed the baby, you just suture. Myomectomy or removal of fibroids will be done electively thereafter, not during cesarean section. There's no place for removal of fibroids during cesarean section because that can cause a lot of bleeding, a lot of bleeding. There's no place for that. A woman will ask you and say, as you do a cyst, I cannot remove fibroids. Say, no, 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 no. Because once you have had a fibroid myomectomy, it's always a cesarean delivery. And the chance of cesarean section in a patient with myoma on the lower segment is a cesarean section. Postpartum hemorrhage after delivery is very common during fibroid. So all women with fibroid should be prepared to have, majority of them, not all, I'm sorry, fibroid, especially on the lower segment, they should be prepared to have this type of operation. And after this, they should be prepared also to go for another operation, which is removal of fibroid. And the surgeons who does this operation must be prepared to do cesarean hysterectomy should bleeding occur. You must be able to do it. And must be prepared to go again after 2-3 days if she has got secondary bleeding. Fibroid in themselves, there's no standard management. There's somebody who can say, I'm good in fibroids, I never have complication. Whenever I operate on Caesar with fibroids, I don't sleep. I make sure that I monitor that woman like a hawk so that she doesn't bleed. Because when she bleeds, she doesn't invite you and say, I'm going to start bleeding. But after 4 or 5 days, if she hasn't bled, chances that she'll bleed are very, very rare, very little. Ladies and gentlemen, we have done fibroids like this, and this is near the end of our slide. The fibroids, tumors of the uterus, are the commonest tumors in the female body. Nearly 80% of African women with fibroids will have infertile. And about half of the women who are listening here, I'm sure about half they've got fibroids of variable sizes. It's better, it's a calling from me that this month of July, which is fibroid awareness, go to the nearest gynae. Just go for a general checkup and specifically mention that you want to check whether you don't have a fibroid. If you don't have a fibroid, hooray, buy yourself a Kentucky and enjoy. If you get them, you'll plan the management with your caregiver. That's the only way you can do it. Thank you very much, ladies and gentlemen, for listening to me all these hours. It was a very pleasant to be with you here. I will take questions and answers very soon. But firstly, before I do that, I want to make you to be able to unmute yourself. I have loaded a new Zoom here. It is 115 participants. Can you unmute yourself? Show me slide control.
Hello?
Can you unmute yourself?
Yes,
Unmute
we
yourself
can,
and ask questions.
Yes.
How about we raise hands then so they can be ordered?
Did you raise your hand?
No, I'm just suggesting that we have we must raise hands
You
so they
just
can
go
be
down
ordered.
on your phone or on your thing. You'll see controls there and you raise your hand. And I can see you here. Let me maximize and make it here gallery and maximize my gallery. Okay, I see AB and Zoom user and Sandile Chawalala's hands are up. AB, comment or question, my friend? If AB cannot, can you hear me, AB?
Yes, I can.
Just talk loud, AB. You're not loud.
Faint. Oh, okay. No, yes, I can. I can hear you. Can you hear me?
Yeah, I can hear you.
All right. So I wanted to know, seeing that you mentioned, Uguti, we can we can go and get ourselves checked up, right? Do we perhaps go specifically to gynaes or?
No, a GP can do that.
A GP can do that.
Yeah.
Okay.
A
No, thank
GP
you very
can
much.
do that. You've just got a sauna, because for you to do that, you've got to do transvaginal sauna, you know.
Okay, so now you're not taking any of your medication, only the medication we're giving you, isn't it?
No, one told me to stop.
I can't hear.
Now I was still talking and I got interrupted.
Okay, talk, AB.
I think somebody else asked a question. Yes. So, just want to find out when an example, when I was pregnant, I was told early in the pregnancy that I got fibroids, but they will disappear during the pregnancy, which they did, or at least I think they did. Okay. So, is there possibilities that
fibroids don't? I'm sure they were not.
Are they common though? Okay. So definitely I should go in and check myself out. That's what you suggesting.
Yeah. When you are non-pregnant, a good transvaginal sauna should be able to tell you that you have or you don't have.
Okay. Thank you so much.
Zandile Chabalala.
Yes, Dokotela, it's Sandile
AB,
Chabalala.
just raise your hand down. AB, mute and put your hand down. And then Zandile Chabalala.
Yes. I'm in KZN. I've had a patient with a fibroid and was told by a specialist that they want to do embolization, but she still wanted to be pregnant. What I do not know was the size of the uterus. My advice was that she should not then rush into the embolization. Rather check the chances of pregnancy first. But the doctor was advising contrary to what I was saying.
I think
I'm wondering what is the best treatment, and at what size do you take that chance of embolizing and hope for a pregnancy at some stage?
And as I said, when you embolize, that blood vessel that you block does not only supply the fibroid alone, it supplies also the uterine wall on that area. So as you are making the fibroid ischemic, you are making the uterus ischemic, even the endometrium there is ischemic. Then you are making that woman subfertile. That's why, irrespective of the size of the fibroid, embolization is not an optimum treatment for a woman who desires to fall pregnant again. It's for a woman who doesn't want to be desired for pregnancy, but who has got symptoms like menorrhagia and pain. Then you can make that uterus, cut the blood flow to that part of the uterus, because the blood vessel that you block is not only supplying the fibroid, also the uterus in that area will be ischemic. In that way, there won't be enough endometrium which will proliferate and secrete and be ready to become a decidua, ready for implantation. Implantation will be poor or absent. I think I buy your idea. I'm with you. I don't know why the doctor said so, but it's not, even the literature doesn't support that. There's a
thank you, doctor.
Who said Zoom user. Then we'll follow Chweni and Karabo. Zoom user, you have been raising the hand, but your phone is not named. It's called Zoom user. You know yourself, there are only 3 names here. Chweni, Karabo. Anybody who's not Chweni, who's not Karabo, who has got his hand up, can talk. His name is Zoom user. In the meantime, I'll greet Dr. Mlate. Mlate must, I haven't seen her for a long time. She must talk. Okay, Chweni, Zoom user is not talking.
Hi, doctor.
Hello.
Hi, Dr. Mahapa. How are you?
Hi, Kim Mashivani.
Yes, it's Mashivani.
Okay, Mashivani, talk.
Yeah, I once had an ectopic pregnancy. Is it possible that it was caused by fibroids, or it's something that is separate?
No.
And I also have a history of fibroids, and I don't have any kids as yet.
I don't think, as I said, fibroid can cause infertility. If there's ectopic, probably there's problem with either tubal mucosa, tubal shape, tubal infection, something that disturbs the fertilized egg from reaching the uterus within 4 to 5 days. In that, after fertilization in the ampulla of the tube, it takes 4 to 5 days for the fertilized egg to reach the cavity of the uterus. Something happened in the tube and delayed that process, and it implanted in the tube. That is the pathophysiology of ectopic. But fibroid never. The fibroid will give you infertility. not ectopic, very rarely. Let me just say no, it's not because of fibroid. It just coincidentally, you are like you've got fibroids and ectopic.
Okay.
Just go,
Thank
let
you.
them advise you. If the fibroids are small, remove them and go for IVF.
Okay. Thank you, Doc.
Karabo, are you there?
Yes, good evening. How are you?
Hello, Karabo. From where, Karabo?
Mulima.
What do you mean about?
Ndione.
Come on. What you mean about
I want to know, Uri, what size do you regard small, yeah, fibroid? Because I went to a gynecologist last week, and no, it was on the 26th of June. Then she told me, Uri, she did it. What do we call that?
The trans
sauna, that one that she inserts down
Transvaginal
there.
sauna.
Yes. Then she said it was 6 centimeter, Ane. So I want to know, Uri, I'm 21 years of age, by the way. So, and I have 0 children. So I want to know, Uri, do you regard that as a small fibroid, or
It's
if
very
I should
small.
have
6
that
centimeters is
removed?
very small. 6 centimeters. If it's one solitary, it's very small. Unless there are many 6 centimeters, like the uterus that I've shown. If it's one, it's very small, and the operation might be very easy. How old are you?
22.
22. I think I would say remove it, because by the time, if you want to have children at about 27, 28, it's about 6 years from now. It might not be 6 centimeters, it might be 12 or more. I would say I'll just remove it now while young. And even if you are not desiring a baby, remove it now and go for annual checkups to see if you don't develop another fibroid, because fibroids are fibroid. People who develop fibroid, you remove one fibroid, after 5 years, it develops another fibroid. If you don't develop another fibroid, by the time you are financially and academically well qualified, you can have a baby, while the fibroid was removed was small. Because why I say so, if the fibroid is big, the type of incision that you made there is big also, and the operation becomes big, you know. So that's why if there's that controversial matter that some people will say observe it. But if you observe it for a longer time, by the time you remove it, the uterus might be so big that it doesn't warrant myomectomy anymore.
Okay. Oh, I have last question. You said there was a point on your slide where you talked of the medical management, then you mentioned oral contraceptives, Anne. So I want to ask, Ore, what do you say of those patches, the patch? Do they
Clemara patch. No, Clemara patch is not is a monophasic contraception. And when I say oral, I should have said biphasic oral contraception, because you want to control the hypothalamus pituitary gonadal axis to increase the rhythm. That's symptomatic management. You want that irregular menstruation to be synchronized and become regular. That's what you treat. It doesn't mean you are treating the fibroid person. You are treating the symptoms of fibroids with oral contraceptive, the combined oral contraceptive. Progesterone only does not. It's like Depo-Provera, which is progesterone only, does not. Microval, which is a tablet, which is progesterone only, does not. Same as Clemara patch, does not. It must be a combined oral contraceptive. Must have progesterone and estrogen inside it. Then it can regulate the cycle.
Okay, thank you so much.
Hope. Lola, please mute. Or if you want
Good
to
evening.
raise your hand, Lola. Hope.
Good evening, Doctor. This is Tulu Fellow from Pretoria.
Oh.
Thank you thank you so much for the enlightening session. I just wanted to find out, this is my first time connected to this webinar. I just want to find out if will there be any sessions regarding endometriosis and their various stages. I've just had a laparoscopy in June, but that was for the removal of the fibroids. But then during surgery, they detected that I'm at stage 4 endometriosis. Thank you, Doctor.
I did endometriosis somewhere last year. You are the 10th, if not the 20th person who requests me to repeat endometriosis. Because by that time, my webinars were not much publicized. And I said November I'm going to close with endometriosis. I'm going to repeat endometriosis. Yona, urinary incontinence, genital prolapse. I'm going to do them November, December I'm not doing. November, October, September, I'm going to do repeats. So be sure they're going to be there. If you get my invite, I don't know how you get my invite. Anybody who can, if you've got a pen, if you send an email to mahapa@drmahapa.co.za and send your number there, your phone number. My office will put you into the database and will send you an invite. You send an email to mahapa@drmahapa.co.za, which is mahapa@drmahapa.co.za. Then they can put you in that and then they'll find an invite. But usually people get invite from by the spirit from who sent one is sharing with other people. That's how they got it. Yes, the answer is that I'm going to repeat it this year, but it's November.
Thank you, Doctor.
Right. Chenile fibroid user. Le S ke sole mutland. Msola, your hand is up. How are you, my friend?
Rona le kae?
Ron.
A ka kgona go kwa ka moka topic ya lena be ke sa le busy ma ke jo etsana staffnyana.
We're related to fibroids.
Yeah, hello. Was there any case of fibroids in teenager? Number one. The comorbidity of fibroids and endometriosis. Can you just comment on those?
Yeah, I touched it a little bit. Usually when you've got endometriosis, what it presents with pain during menstruation. Fibroid present usually not with pain, but with heavy menstruation. So if you've got comorbidity with that, we'll have heavy, painful menstruation. The heaviness of the menstruation will be from the fibroids increasing bleeding surface area and interference with the clotting mechanism. But the pain will be from the usually pelvic endometriosis, because as the endometrium in the uterus slot off, the one in the peritoneum, in the pelvic cavity, also it bleeds and causes that pain. If they coexist, you've got a very heavy, painful menstruation, and with fibroids, chances are that you've got coexisting endometriosis coexisting with myomatous uterus. Another, when it comes into fibroids in young people, teenager, although it's uncommon, but it is there. You can find small fibroids in young people, because in the introduction we said that although we don't know the cause of fibroids, it tends to run in families. There hasn't been a genetic link that can be ascribed to say chromosome number this, it does like this, it can be explained. But epidemiologically shows that if somebody has got a fibroid, chance that one of the first degree relatives, a sister or a mother or something, also has a fibroid. So if people have got such family history of fibroids, such that he can, as a teen, he might have a fibroid, but it's very rarely found, but you can find it. You can't say, nothing you can say is never in fibroids. And if you find fibroids in a teen, the commonest symptoms will be heavy menstrual bleeding in a teen, because the teen doesn't want to fall pregnant, so it won't be infertility. I think that's my answer.
Thank you, Doc.
Thank you. Training Zoom, I'm sure they didn't even know that they've got their hands up. Without
Good evening, Doctor. It's Training here.
Training from where?
Training from Muleti.
Mulechama.
I'm Muleti. I'm Tom.
Mama Ruman Maria Tomeleja Lelu Luswana Lushungwa Lona Vele Yatuka. Bugbiala Mulech, Lamatala. I don't talk for you, chain.
Can I read this problem? Ne? I don't know if ever that could be the reason you're can I do fibroids or what. Can I irregular periods? This month they can be very, very heavy with pains where I'll sometimes give out dizzy, of which I don't know why I give out dizzy. And then there was a time when bar ovarian cyst, and then by the surgery, then bar buying chiche. But then somewhere along the way, I went for the second surgery for that as well. Then I'm actually busy with that thing. They said to me, my tubes are blocked. So the SOMAR did everything all together. But then I thought maybe after that, everything will be fine. I'll be able to have a baby. But then now I'm still struggling. My periods went back to that irregular. Sometimes I might not see it in 2 months and it comes back after a month. Then you have a heavy. Sometimes you have a little bit, maybe for 2 days. Then get a mass. So I don't know what could be the cause of that, or does it need a serious attention on medical or what?
I think in that case, it might not be just an organic cause like a ovarian cyst. They might have endocrine, there are a lot of endocrine conditions that can affect the menstrual endocrinology. You need to have a good endocrinological workup by fertility specialists to check whether your hormones from the pituitary, from hypothalamus to the pituitary to the ovary, the response are well regulated. Usually your hypothalamic pituitary gonadal axis need to be evaluated. I think yours irregularity of menstruation might be hormonal. I'm not saying it can be a cyst, because once you remove a cyst, if it was a functional cyst, the symptoms should go away. But if they don't go away, then I'll check the hormones. I will advise you, look for a gynecologist who's interested in fertility. There are people who are, their interest is just in fertility. They are called reproductive specialists. And go and give him that history. He might find that maybe it might be thyroid problem. It might be endocrinology. On history alone, I can't tell you, but I don't think there's an organic cause like a cyst or a fibroid. You need a full workup, more so that you want a baby. If it's organic, it's an endocrinological cause. It will also make you unovulation, find that you are not ovulating. My advice to you.
Yes, that's what they said. They said I'm not ovulating.
Yeah, it says endocrinological, but you can't say it's this one. They are many. They've got to take bloods and do a lot of tests to see which organ, which hormone is in excess, which hormone is antagonizing which hormone is not stimulating which one, and then they can find a solution. Usually it's not one consultation where you can find the thing. They might do this test, next time they say it's not this one. Let's do this one, permutation, until they find something. Okay, thank you.
Okay. Thank you.
Thank you, Trinity. Take guys and down. 105428843. Mute. I'm asking you to mute. Ladies and gentlemen, without any other question, I would like to thank everybody who attended this webinar today. As usual, I don't know what I'm going to present.
Excuse us, Doctor. There are questions on the chat. Maybe if you can address them, the ones on the chat. Thank you, sir.
Let me see. Where is the chat? You know, you say you are chatting. Eh? I'm going to see the chat after. Oh, there's 11 questions. Eh? Show chat preview. Okay, why did my doctor not pick up what I had fibroid? Had 3 miscarriages, gave birth to an autistic boy, 17 years now, and it's my burden because of doctor's oversight. But fibroids don't talk autism. You can't say because you had fibroid, the baby is autistic. Autism is not caused by fibroid. It doesn't like your baby's autism. After losing so many pregnancies, only then he referred me to a gynecologist, and a big fibroid was removed through total hysterectomy. I'm saddened. Of course, if a fibroid is big, you'll have hysterectomy. Really, I can't answer this question because really it's between you and your doctor. I don't want to blame any colleague. That was from Goli. Thank you very much. God continue to bless you. This is very informative. Any office in Pretoria? No, I closed an office in Pretoria. Samsung, what an informative presentation. Job well done. Okay. What must we for after uniting ourselves. What does he mean? I don't know what must we for after uniting ourselves? I don't think he was referring to me. And Natsikuno is just thankful. What a very informative session. Precious Mamburu. Kaulanga. Good evening, doctor. So my concern is that I have been doing routine checkups at the gynae, and I have been checked for fibroids as I was planning to fall pregnant, and nothing was detected. I went on to fall pregnant, and in my first sauna, gynae also checked for fibroids, and nothing was detected up until my third sauna. Soon after that, I started experiencing sharp pain, and to my gynae, and they said I have multiple fibroids. So did they grow because of the hormone? No. They are very slow growing tumors. Probably somebody missed them. During the fibroids are not fast growing. They are unlike cysts. They grow very slowly. In 9 months, they can grow by about 1 or 2 centimeters. No, I don't think it developed that time. Even if they're multiple, you had them all along. Can we have the email return, please? Email is, how do I write it here? People think I'm a techno-weavy. Mahapa at drmahapa.co.za is Mahapa at drmahapa.co.za. Somebody can write it here. Mahapa at drmahapa.co.za. Small letters. Very educative session. Shoe editor. That's the email. Thank you very much. Baldwin, thank you very much for informative webinar. Looking up for more. So that's the email. You can put your cell phone there. We will all put the cell phone must have a WhatsApp. Even your email, you can put it there. We'll put you on the database. My office will inform you. Ladies and gentlemen, it was a very informative, good session, and we really enjoyed being with you. Thank you very much. I'm going to log off.
You log off too.